My name is Robert Hardi. I'm a gastroenterologist internist. I just recently returned to Hungary. I was born here. I actually grew up here and went to school here and began my training as an internist here. I left in the late 70s, lived in Germany, set forth my training in Germany and then in the United States. I received training both in oncology and in gastroenterology, and I am board certified in gastroenterology and in internal medicine. My gastroenterology training was finished at Cornell University Medical Center at the New York Hospital in New York City, after which I moved to Washington, where I've been in private practice for about 40 years. My practice is in garden variety general gastroenterologist, but I did have an interest from the beginning in inflammatory bowel diseases, and I've been partnering with the local Crohn's and Colitis Foundation of America, and I served 3 years on the national board. For about 25 years, I established and ran clinical research center for gastroenterology for a large GI practice, in which we did all sorts of studies, where I was principal investigator in 400 studies, about half or more of which were in inflammatory bowel diseases, but it also encompassed anything and everything, including colonoscopic techniques, different preparations and sedations. I served as a member of the board of the Association of Clinical Research Professionals, and I was twice chairman of the Academy of Physicians in Clinical Research. I have not done clinical research since 2019, I think. But I do anything and everything. My interests are not just, as I said, inflammatory bowel disease, which of course I'm happy to do even without ongoing research background, but also because that is really very important, and I've also done some actual work on it, is colon cancer screening. We did do work with non-invasive colon cancer screening. Those methods are not available in Hungary, but even if they were available, they are definitely secondary to my favorite and everybody's favorite methodology is colonoscopy. Maybe not the patient's favorite method, but it certainly is the best that there is. It is the gold standard of colon cancer screening. Non-invasive tests do have a place, but only if there is some either contraindication or some absolute refusal to accept or non-availability of colonoscopic screening. We've been doing colonoscopic screening for, we say colon cancer, but in reality it's not just for colon cancer, but for colon polyps, which have been established as the forerunners of colon cancer since the early 1990s. The pivotal studies of Dr. Winover at Sloan Kettering that really established forever that there is this adenoma-carcinoma sequence, that there are benign polyps, some of which, not all of which, but some of which might become cancerous, and these will be responsible for about 85-90% of all colon cancer that there is. It also means, by definition, if there is a long, about 7 years or so on average, evolution from a benign polyp into a malignancy, then it gives us an opportunity not just to screen and diagnose, but also to intervene. So the point of this colonoscopic screening is not just to diagnose colon cancer. And of course, if you want to diagnose this colon cancer at an early stage, the chances of recovery are far higher than in a late stage. Stage 1 colon cancer is 95% curable. Stage 4 colon cancer is less than 5% curable. It's getting better now, but still it's dismal. But we basically can identify colon polyp, we can remove colon polyps, and we can actually interfere and stop colon cancer from developing, which is actually easily seen because the mortality and the frequency of colon cancer in the screened population has dropped remarkably. Unfortunately, Mother Nature being what it is, the time spectrum of colon cancer or colon polyps has shifted down the age curve, and whereas when I started my career, finding colon polyp, let alone colon cancer in the 30 years old, was a highly exceptional occurrence. Now it's getting more and more routine, and it's been publicized in the lay press too. We don't know why that happens, but most likely because of lifestyle, because of what we eat and how we exercise, and how that influences the microbiome that we have in the gut. I'm sorry I digressed as to who I really am and what I really do, but so colon cancer screening is very close to my heart and it's very important. I've done, somewhere between 20 and 30,000 of these procedures in my life. So I think by now I know how to do it until I forget how to do them. Again, I don't just do colon cancer screening or take care of inflammatory bowel disease patients. I've taken care of all other, or almost all other gastrointestinal illnesses, from abdominal pain to gastroesophageal reflux, GERD, so-called heartburn, dyspepsia, basically everything else, diverticulitis, biliary diseases, and even liver disease. So I'm willing to see basically anybody who thinks that I can help him or her.